Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Today we're going to be talking about gallstones and cholecystitis. Let's start with gallstones, also called cholelithiasis. These are solid particles that form inside the gallbladder. As long as there's no inflammation around them, we call it just cholelithiasis. Many people don't even know they have gallstones. They are often found by accident. But when they do cause symptoms, it's usually after eating fatty food. That classic pain in the upper right abdomen is called biliary colic. There's a classic set of risk factors known as the 5 Fs: female, fat, fertile, 40, and a family history or diabetes. Ultrasound is our first tool. Gallstones appear bright and cast shadows. They usually move, so turning the patient helps confirm if it's a stone or not something stuck in the wall like a polyp. So this image is an image of a single gallstone. It's a sagittal ultrasound of the gallbladder, and it shows an echogenic gallstone that's marked by these calipers in the gallbladder neck, with posterior acoustic shadowing here, shown by these yellow arrows. Sometimes the gallbladder is so full of stones, it's hard to see anything. That's where we look for the WES sign, the WES sign, or the wall echo shadow sign. So we see wall, echo, and a shadow. It tells us the gallbladder is completely packed, either with multiple stones or one very large stone. Things that can mimic stones include sludge, polyps, porcelain gallbladder, which we'll look at later, and even bowel gas. Knowing how each one looks on ultrasound helps tell them apart. So this image is depicting the wall echo shadow sign on ultrasound. We see two parallel echogenic arcs representing the gallbladder wall, that's the first one, and the leading edge of the stone that's pointed to by the yellow arrows. So we have the gallbladder wall being the first echogenic line, and then the leading edge of a stone or multiple stones shown by the second echogenic arced line. And there is an intervening thin layer of hypoechoic bile. If you notice, between these two echogenic lines is this hypoechoic space between them. That's the hypoechoic bile there. The gallstones cast a prominent shadow, obscuring evaluation of the remainder of the gallbladder wall, as is seen in this image. Now let's talk inflammation. Acute calculous cholecystitis. This happens when a stone blocks the gallbladder neck or cystic duct, causing swelling and infection. Patients usually have pain and fever. No single sign confirms it, but ultrasound gives great clues. So you may see stones, you may have pain when pressing the hypochondriac region, something we call the Murphy sign or the sonographic Murphy sign. You could have a thickened wall of more than 3 millimeters. The gallbladder may be enlarged. You may have pericholecystic fluid and extra blood flow or hyperemia seen on Doppler. So these images are cases of acute calculous cholecystitis. The first one is a coronal T2 MRI, and it shows gallbladder wall edema that's pointed to by the yellow arrows. We can see this changing signal of the gallbladder wall, showing some fluid accumulation within the walls. And there's perihepatic and pericholecystic fluid. So we see this perihepatic and pericholecystic fluid around the gallbladder and the liver. We also see small T2 hypointense stones within the distended gallbladder, and some are even seen at the gallbladder neck. So this is a case of calculous cholecystitis, acute calculous cholecystitis. Now in this ultrasound image, which is also acute calculous cholecystitis, it's an oblique sagittal ultrasound through the gallbladder, and it demonstrates a thickened echogenic gallbladder wall. The gallbladder contains numerous echogenic gallstones, tiny echogenic gallstones here. So this is also a case of acute calculous cholecystitis. If left untreated, cholecystitis can become serious. You may have complications including emphysematous cholecystitis, gangrenous changes, and even perforation, where bile leaks into the abdomen. The usual fix is gallbladder removal. That's a cholecystectomy. But if a patient is too sick for surgery, a tube can be inserted to drain it temporarily until they are stable. That's a cholecystostomy. Now, acalculous cholecystitis is the same inflammation, just that there are no stones. It's acalculous. It usually shows up in very ill patients like those in the ICU. They are often too weak for surgery. And like we said before, if a patient is too sick for surgery, a drain is placed. And for these patients who have acalculous cholecystitis, the drain might be all they would need. That could actually be the mainstay of treatments for them. They might not eventually even need the cholecystectomy in the long run. Now, emphysematous cholecystitis is a severe complication of acute cholecystitis, and it's caused by gas-forming bacteria. It is rare, but elderly diabetic patients are more susceptible. On imaging, gas may be present either within the lumen or the wall of the gallbladder. Now, treatment of emphysematous cholecystitis is most often emergent cholecystectomy or cholecystostomy in patients with a very high surgical risk. So the first image is a grayscale ultrasound, and it shows diffuse echogenic foci within the gallbladder wall corresponding to intramural foci of gas on axial CT. And this was a case of emphysematous cholecystitis. Now, gangrenous cholecystitis is due to increased intraluminal pressure, leading to gallbladder wall ischemia and necrosis with high risk for gallbladder perforation. On imaging, gallbladder wall thickening may be notably asymmetric, and intraluminal membranes may also be present. Treatment of gangrenous cholecystitis is emergent cholecystectomy or cholecystostomy, just like the emphysematous cholecystitis. So this coronal contrast enhanced CT shows gallbladder wall edema and pericholecystic fluid, and there's also discontinuity in the enhancement of the medial gallbladder wall here due to necrosis and perforation with spillage of contents into the right subhepatic space here. This was a case of gangrenous cholecystitis. Now, acute gallbladder perforation has a very high mortality due to the generalized bile peritonitis that ensues. Subacute perforation may lead to pericholecystic abscess formation, and a chronic perforation may cause a cholecystoenteric fistula. Now, to porcelain gallbladder, this describes a peripherally calcified gallbladder wall, thought to be a sequela of chronic cholecystitis due to either chronic irritation from supersaturated bile or repeated bouts of gallbladder obstruction. Porcelain gallbladder is associated with a somewhat controversial increased risk for gallbladder carcinoma. Historically, prophylactic cholecystectomy was the standard of care. However, some advocate for observation in asymptomatic patients. So this axial CT scan shows this peripherally calcified gallbladder wall with some gallstones within. Actually, porcelain gallbladder is almost always associated with some gallstones, as seen in this image. Now, to Courvoisier gallbladder, it refers to a markedly dilated gallbladder, originally described as being so large to be directly palpable on physical exam, and this is from malignant obstruction of the common bile duct. A markedly distended gallbladder without acute cholecystitis implies chronic obstruction of either the cystic duct. So you see that the gallbladder is very distended and there is no inflammation. So this tells us that the gallbladder has actually had time to distend. So this is chronic obstruction and not in the acute setting like in acute cholecystitis. So this first image is a sagittal ultrasound of the gallbladder, and it demonstrates a massively distended gallbladder. The common bile duct here seen in this image is also distended due to chronic malignant obstruction. Thank you very much for your attention. I hope you found this helpful and useful. If you did, give it a like, share to someone you think might need it, and subscribe if you have not subscribed yet. The next thing we're going to talk about is hyperplastic cholecystosis. I will catch you guys in the next one.